openIMIS is a versatile open source software which supports the administration of health financing and social protection schemes. It is recognized as a digital public good by the Digital Public Goods Alliance and is listed in Digital Square's Global Goods Guidebook as an emergent global good in digital health. openIMIS can be downloaded, adapted, and freely used anywhere in the world. What sets openIMIS apart? For efficient delivery, health financing and social protection schemes require complex processes with high volume data flows. openIMIS is designed to manage these processes by seamlessly integrating beneficiary, provider, and payer data in a single platform. In Nepal, openIMIS has been used to manage the social health insurance scheme since 2016. With openIMIS, processes such as enrollment and claims processing have been made easier. With the Android-based enrollment app, enrollment assistants can go door to door to register households to the scheme. And a web-based claims entry reduces paperwork for health facilities, enabling the Health Insurance Board of Nepal to achieve a rapid rate of expansion, rolling the scheme out to the entire country in the last 6 years. openIMIS is flexible and can be customized where needed. In Cameroon, openIMIS supports the HIV user fee elimination scheme. The goal of the Ministry of Public Health is to remove all user fees for HIV testing and treatment, but there remains sensitivity around collecting data from people living with HIV. The flexibility of openIMIS allowed customization to manage beneficiaries while collecting the least possible amount of personal identifying information. Based on its modular design, openIMIS is versatile and can be adapted for different uses. In Nepal, in addition to health insurance, openIMIS has also been used to manage an employment injury insurance scheme, which offers coverage of medical expenses to workers in the formal sector following an employment-related accident. In Cameroon, openIMIS is being customized for voucher schemes for maternal care. And in the Gambia in 2020, openIMIS was adapted to manage the largest cash distribution scheme in the country's history, with the goal of protecting poor households against the economic effects of COVID-related lockdowns. openIMIS has been developed with interoperability as a priority, and because it is built in accordance with industry standards, can communicate seamlessly with other systems. In Tanzania, where openIMIS is used for the Community Health Fund scheme, openIMIS is integrated with other government systems, such as the government e-payment solution, allowing beneficiaries to make convenient digital contributions to the scheme from their phone or computer. Flexibility and interoperability make openIMIS a sustainable solution that not only meets the needs of the current moment, but can evolve to meet tomorrow's. When a government, company, or organization starts using openIMIS, they join a global community and have access to the expertise and support of implementers, experts, and software developers from around the world. And the openIMIS community is growing. 6 years of the openIMIS initiative, co-financed by BMZ and SDC, has meant 6 years of expanding use cases, entering new regions, and forging partnerships. Today, openIMIS is used for 11 different health and social protection schemes in 8 different countries, covering close to 10 million beneficiaries. With feedback, knowledge sharing, and code contributions, members of the community are constantly working to improve openIMIS so that more people can benefit from health and social protection coverage around the globe.
Thank you, Cherise, and good evening to everyone. I see there's Maria B joining us in the call. Thank you, Maria, for joining us tonight. Saurabh, thank you for joining us. Um, when we started the DRG journey, it was way back in January when Dr. Bunchay and I were thinking of what's the next uh, level for the Philippines, actually, because we're starting to adopt DRGs in the Philippines quite later than the Thai, who have embraced DRG earlier. So for those who are not familiar with DRG, it's short for diagnosis related groups. It's a classification system that is used by insurance organizations to measure what is the appropriate reimbursement for specific cases and a combination of data that you find in a confinement of a patient. Our friends from Thailand, led by Dr. Supasit and Dr. Bunchay, have been using DRGs for the longest time. Even if they started UHC later than the Philippines, they were able to achieve it much earlier than us. I think in large part because of their investment on information technology and the use of the DRGs. So anyway, fast forward to 2022, we formed the Asia openIMIS community of practice with at least 4-5 countries in Asia. And we're using it in the Philippines right now as part of medical education. Um, and there was a question about, can we make openIMIS also DRG compliant? So we were all scratching our heads back then and we're thinking, so how do you make openIMIS DRG compliant? And of course, it was we turned to our friends in Thailand, Dr. Bunchay and Dr. Supasit, and asked them, can you tell us more about how the DRG system developed in Thailand so that we can learn from your experience? And a part of it is, can we look at your data model and see what are the input data that you collected from the hospitals so that you can create your grouping software, your grouper software, the algorithm. And then we will look at the openIMIS data model and see if the openIMIS data model is ready to be DRG compliant. It was a very, very rough hypothesis of mapping the Thai DRG dataset with the openIMIS dataset. It was sort of like a shot at the moon to find out whether these two databases actually could map to each other, with the end goal of answering the question of yes, openIMIS can be used for DRG, or even no, openIMIS cannot yet be used for DRG because it is still missing some of the data elements that it is not yet collecting, which they have been collecting in the Thai DRG. So this project, and thank you to Professor Joshi for accepting this challenge and the participants in the datathon, was really to link the time and tested Thai DRG data model and looking whether a modern data model like openIMIS is ready to be DRG compliant, and if not yet, then what are these data elements that we can add to the openIMIS data model so that it is closer or even fully compliant to a DRG database system. So that's the long and short of how we arrived at this point, where Professor Joshi will now show us the results of this comparison of the data set of Thai DRG, the time and tested, and openIMIS, the future-looking insurance management information system. Thank you, Cha.
Thank you, Dr. Alvin. Next, we would like to call on Sir Saraf to briefly talk about openIMIS.
Sure. Thank you, Chad. Thank you, Dr. Alvin, for that introduction to the work. that Dr. Basanta will be presenting. From the openIMIS initiative, we're very glad to have partnered with AHIN and Dr. Bunchai and the Thai DRG team to really understand what it takes for implementing a DRG, particularly with foreign information systems such as openIMIS. So as you all know, openIMIS is a information system that's really tailored to manage various social protection schemes, particularly social health insurance. And we know that a lot of countries are now looking into DRGs or wanting to implement DRGs in their various health insurances. So we wanted to be prepared for that and make sure that we are providing a solution that is compliant to the various needs in the region. So that's why this work was undertaken, and I think it's very interesting what Dr. Bunchai and team have done, as well as Dr. Basanta and his team. So I think there's a lot for all of us to learn here, and the openIMIS initiative will make utmost use of this knowledge to move forward. So thank you very much, everyone, and looking forward to the presentation as well as the ensuing discussions. Thanks. Over to you, Cha.
Thank you, Sir Sarav. Now we have passed the microphone to Dr. Bunchai to talk about Thai DRGs.
Thank you, Cha, and thank you, colleagues. I think the Dr. Alvin and Saurabh have been talking about the starting of this project. I am a little bit surprised that how we're gonna do that, but thanks to the GIZ that to encourage us to create not just the webinar series, and we're going to be more educational products, but also the exercise to do the datathon. I mean, working in practice to look at the information need in to develop. Let's say to develop the DRG, and thanks to my our professor, Dr. Supasit, that he has a more than 30 years experience on developing Thai DRG. It's starting as the research projects, and working is for more than 10 years until the country implement the universal healthcare coverage in 2002. That's starting to kind of use the Thai DRG in real world, in real world. Before it's kind of the piloting in several insurance terms. Thai DRG is financing tools to pay for the acute care in the hospitals, and I think this is a kind of the solution for our universal healthcare coverage implementation, that to pay the provider as I mean fairly as it could. At the same time, the country can be managing the finance, the health expenditure in the country. And along these 15 years, it proved that these financing tools are useful. And we are happy that if our knowledge that we accumulate for the last 20 years can help our friend to implement USC, that would be good. And the openIMIS also opened the door for country to leapfrog on having the insurance management information system. So this is a good time that to explore more the opportunity that the openIMIS that can be available as a global good to expand the functionalities of providing the financial tool as using Thai DRG as the the sample to look for the information model in openIMIS and the data need for calculate the Thai DRG. Thank you for Dr. Pasanta that organizing the datathon. I think this exercise could enrich our knowledge about the health information system, especially in the use case of the insurance services, insurance and USC a lot. Thank you.
Thank you, Dr. Bunchay. And now we'll pass the virtual floor to Professor Basanta to present the results of the datathon.
Thank you very much, Dr. Alvin, Dr. Bonsai, Dr. Saurabh, sir, from GIZ for helping me, for introducing me to this AEN and helping me to conduct this openIMIS-DRG datathon. So I'm presenting the results of the openIMIS datathon. Before moving to the results, so I'll briefly talk about what we did for organizing this datathon. So first, I would like to present the timeline for the datathon. So actually what we did was we opened the application on May 18. Then application was closed on May 31st. And the selection of applicant was done on June 1. And they were informed about their selection on that day. Then the real datathon started on 3rd to 5th June. And in that day, the orientation and interaction session was held from 12 p.m. Nepalese time. And then on July 4th, the award ceremony was held and the award was given to top 3 contestants and a consolation prize was given. So there were 19 teams which submitted which registered for the datathon. So they were basically from Triveni Institute of Engineering, Triveni University, and the colleges under Institute of Engineering. So Puljo campus, Purvanchal campus, Kopa College of Engineering, Paschimanchal campus, Sagarmatha Engineering College, and Thaptali campus. They collaborated with different universities and different medical institutes that are in Nepal. So London Metropolitan University, Kathmandu Institute of Child Health, Maharajganj Medical Campus, Civil Service Hospital, School of Medical Sciences, Nepalese Army Institute of Health Sciences. So they collaborated with different this organization and this medical institute. So out of that, we selected 14 teams and they were led by one team member. So as mentioned earlier, so we organized an interaction and orientation session on 3rd of June between 12 to 3 p.m. In that interaction and orientation session, Dr. Banchai presented about this Thai DRG. Dr. Dragos and Eric presented about openIMIS and openIMIS data model. Dr. Roshan Kozu presented about the SSF and their uses of openIMIS in the context of Nepal. And Dr. Alvin summarized about datathon and the concept, why this datathon was organized, like he mentioned in this presentation. So the main theme of this datathon was to compare openIMIS data model and Thailand DRG data model. So the team were given a set in which they have to map the openIMIS and Thailand DRG table and field name. So the mechanics for this DRG datathon organization was they had to first register through the website, then they had to submit the mapping through Google form, and a second prize of 300 euro and third prize of 200 euro was given. So these were the teams which submitted the file mapping file. And out of these 13 teams, so the comparison was done by the team, especially with the help of Eric and Dr. Dragos from openIMIS team. And then that was very precisely evaluated by Priya from the Dr. Banchai's team. So based on that, we found out that this team, which the team was named as Trinity, they were marked as third runner-up, and they obtained the prize of €200. And they were from the Pulchok campus and Kathmandu Institute of Child Health. The medical professional in this team was Dr. Srishti Singh, and the other members are Ranjuji C and Supriya Kharka from Pulchok campus. The second award, second runner-up was also from the Pulchok campus. The team was named Hufflepuff, and they received the prize €300. They collaborated with Maharajganj Medical Campus. He's a Brahim Sapota and he's Prasant Sesta, and they collaborated with Dr. Bidur Adhikari. And the winner of this datathon was the team Cartographer, and they are from Pulchok campus. They received Euro 500, and they collaborated with School of Medical Sciences. So this is Rohan Chetri, this is Nikesh DC, and the person is Ravi Pandey, and then Dr. Neeraj Bhandari. So, and we also given the consolation prize to the team apart from Pulchok campus, 075 batch. They receive Euro 50. They are from Kopa College of Engineering School. They collaborated with School of Medical Sciences. The team consists of Anish Silpakar, Sudeep Manandar, Juel Fanju, and Savin Lawaju. So this is the result of the winners from the datathon. So now I would like to present the result of this datathon in some of the slides. So before moving to that, so I would like to share what has been already shared in other presentation, but I would like to talk about what are the important tables which we use for comparison out of the database script available in GitHub. The 67 tables can be created for openIMIS. Out of these tables, only 10 tables related with claims were fallen in our interest zone. And when we checked the number of fields from these tables, so we found that there were 227 fields, and the most field was in the TVL claim table. And so these are the number of fields available in openIMIS table. So when we looked up in the Thai DRG, there were 16 files in the Thai DRG. So this is the ER diagram for this Thai DRG table. So whenever we try to find out the interesting tables for us, so we found that there were 12 tables that are interesting related with claims. So these are the number of fields, and we can see that there are only 111 fields in this Eclaim dataset, Thai DRG dataset. And we can see that there is information about insurance of patient, and there are information about the patient. There is information about patient, there is information about outpatient and inpatient, and there is information about diagnosis and procedure related with outpatient and inpatient. So this is the result of datathon mapping. So first, the insurance information of the patient. So we try to map the insurance information of the patient. So we could see that this is the basic reference table is taken, since we are mapping with Thai DRG, the reference table is taken from Thai DRG. And here we can see that this is insurance information of the patient, that is table INS from this Thai DRG. And we could see that these fields are mapped with the the respective fields in openIMIS table, and then we could not find the mapping for these fields: hospital code for main contractor, hospital code for primary care unit, and claim code. So we couldn't find the mapping for these fields. Apart from that, other fields we could find the mapping. Then regarding the patient information, we find a lot of fields that are related with the patient. So we only could find a very few fields that are not mapped. And there is some confusion regarding the city code and district code, because this code can be mapped to the current village and current address of the TVL insuree, but since we have only 2-digit code, so it's not sure whether we can map directly with this field or not. Okay, so regarding the outpatient informations, we could see that there are a lot of fields that we couldn't map, and maybe this field are not that significant field. So we have to find out about this field. So we can see that these fields we couldn't do the mapping with the openIMIS dataset. And there is also the clinic information. So we have HF code in openIMIS, but this code is the hospital or primary care point. So maybe that we are not sure whether we could map with this clinic field or not. So regarding the diagnosis of outpatient, so we could see that we could map some of these fields, and some of the field like the type of diagnosis we couldn't find the mapping in openIMIS table, and also the physician identifier license ID we couldn't find the mapping in openIMIS table. Similarly, the procedure regarding the outpatient, we could find some of the mapping, but we could not find, like earlier, physician identifier, and we couldn't find the clinic code in procedure for outpatient. Similarly, for inpatient also, there are a lot of fields which we couldn't find the mapping, and there are some fields we could find the mapping. Similarly, for diagnosis of inpatient, we could find 2 fields that we could map with the existing openIMIS table. And we couldn't find the mapping for type of diagnosis and physician identifier. Similarly, for the procedure related with inpatient, we could find some of the fields, but we couldn't find the mapping for type of procedure and physician identifier. So, and there is some confusion regarding the date. So start date of operation and start time for operation. So we are not sure whether we could directly map with TVL claim date from of openIMIS table, TVL claim date 2 of the openIMIS table. So we have to look into detail regarding that. And also regarding the financing table of the openIMIS, we could find a lot of fields which we couldn't map, and very few fields we couldn't find the mapping. So similarly, for there is another field table, CHA, that is the financing table as per the description. So we could find a lot of mapping, and basically what we can see is there are a lot of multiple field mapping related with openIMIS table. So a lot of fields from this Thai DRG table are mapped with the multiple fields of openIMIS table. So when we try to compare this summarize based on this comparison, Thai Eclaim's dataset, this is the summary what we could find out of 111 11 total. Sorry, I forgot to sum up this up. So out of 111 total number of fields, so only this much of field could map. So it's about so we could see that there are a lot of fields which we couldn't map with the openIMIS table. And like we can see that the major thing is the referral of outpatient is missing in the context of openIMIS. Similarly, referral for inpatient is missing. And also we could clearly see that the outpatient information, out of 15 number of fields, we could only map 5 fields. And similarly for inpatient information, out of 13 fields, we could only map 6 fields. So this is the status of comparison with Thai Eclaim dataset and openIMIS dataset. And regarding regarding the openIMIS, so when we checked with the 10 tables of the claim scenario for the context of openIMIS, we could see that we couldn't able to map these tables: TVL items, TVL families, TVL claim items and TVL admin with the Thai DRG table. So these are the fields out of 227. This field we couldn't map, and so there are a lot of fields, common fields from the TVL claim and other fields which we could map to the Thai Eclaims dataset. So this is the summary, and so talking about the summary of this conclusion of this presentation. So Datathon was organized for IT and medical students, and this is the result which has been developed with the help of openIMIS team, with the help of Dr. Bunchai's team, and finally the result of Datathon. So we could see that openIMIS claim tables are mapped to 10 Thai Eclaim dataset out of 12 tables, and multiple fields from openIMIS table are mapped to Thai Eclaim dataset. And actually there is no mapping for referral tables, both for outpatient and inpatient. And also mapping was found for 6 tables out of 10 claim tables, and less number of mapping for openIMIS to Thai Eclaims was found, especially for inpatient and outpatient information table, and the significance of missing field has to be analyzed. Thank you very much.
Thank you, Professor Basanta. I think there are questions already in the chat box. So if there are other attendees who would like to ask questions, please feel free to type them in or ask through your microphones. The microphones are enabled now. So for the first question, Professor, it's from Dr. Puyat. Do you think it is possible for the FHIR API to facilitate syntactic communication between semantic standards of openIMIS and Thai DRGs?
Thank you for a question, Christian, but maybe I would like to pass this question to Dr. Alvin or Bunchai, because I will not be able to answer this question.
Okay, thank you. I think the question is quite a little bit, I'm not quite sure that I understand well, because of talking about the syntactics and also the semantic standard. Inside the Thai DRG table, when we're talking about the code like the ICD code, or that is a syntactic, we have the standard code for that. And but for the FHIR API, right now we are working on mapping the table data element in the Thai DRG reimbursement data element into FHIR resources, and most of them are able to map with that. So it is possible to provide the FHIR API for the data element of the Thai DRG. So that is what I understand the question. Another question is that maybe the comment from Nirmal that look like Thai DRG include more medical information. That's true. It seems like there is no procedures mentioned in the openIMIS data model, which is the procedure is very important for the calculation of the DRG. Another thing is that to identify which diagnosis is the primary or secondary. To one patient, one admission can be multiple diagnoses and multiple procedure. Something like patient may come up admit to the hospital because of the lung cancer, but he or she may have the underlying or the comorbidity of the diabetes mellitus or the hypertension, or congestive heart failure. So it can be multiple diagnosis and multiple procedure, like some admission, there is multiple surgery. So to identify, to specify which diagnosis is the primary diagnosis is important for the DRG grouper to know that. I think that is the answer. Over to you, Shah.
Thank you, Dr. Bunchai. I think there's another question that I missed earlier from Dr. Puyat.
Thank you, Dr. Bunchai. I was just wondering as well, for our team who's currently doing research on health insurance claims in the Philippines, if we could have a resource that we could use to further study the actual data tables that are used in the Thai DRG, the financing short and financing long, to see how they also map with our claims database.
Oh, there is a detail may I say to further. I don't quite sure about the financing short and financing long. What is mean by financing short?
Dr. Bunchai is table 11 and 12, CHA and CHT. It's
The chart table, right?
Yeah, yes.
Okay.
It's not the discharge table. So on the 12 file, the name of the financing short and long is table called CHA or CHT. Yes. So actually, I'm not sure if we can share the spreadsheet, the Thai DRG in English to Dr. Puyat, maybe.
Okay. I think sorry that I'm confusing about that. For sure that we will look for the more detail about this table. I mean the explanation. Let's communicate after this with Piraya, and we will give you more. I think we the table that it show in for the Thai DRG is the table in to get to calculate the relative weight or the DRG, but to get the DRG system, another part is costing, which is there is a lot of data element that or a lot of procedure to get the chart. I mean the costing that relate to that admission. That is another big data element that need. But in our first, I mean in the early implementation of the Thai DRG, this 12 file has been used, and you can see that there is a chart data element. And from those chart data element, we use it as the chart of the admission, and at the same time, the researcher go to the specific hospital to do the costing, and we make the chart to cost ratio and estimate the cost of the each DRG group to come up with the reimbursement base rate. So I think the Philippine group has been learned a lot from both the algorithm of the DRG and also the data element, the procedure to get the cost chart ratio or the costing from the team of the Dr. Supasit team, which has been I mean consult by the MOH and the field health. I think field health in several occasions. Over to you, Chair.
Thank you, Dr. Bunchai. Are there other questions from our participants? I think there are no questions yet in the chat box. But Sir Nirmal sent a resource link. Maybe the participants would like to check that out. Any more questions?
Yeah,
Nirmal-
sure. Maybe
Yes, Doctor.
maybe get the presentation slides.
I will ask for permission if we can publish the slides.
Yeah,
Doctor?
so could you please share with us?
Yes, noted on that. Thank you.
Yeah, thank you so much.
To me, I think for the open image team, I think the field, the data field of primary, secondary diagnosis, and to accommodate more, not only one diagnosis per admission, might be another next step to looking for for the open image to be used as the data collecting software for the reimbursement that can be go and calculate the Thai DRG for the DRG. The referral is another one is the result of the admission, like recovery or against advice or death. That is also one of the information need to group that admission. And for the same disease, same procedure, when admit the hospital, and if the result is recovery or the result is death, the resource that used for that that admission is not the same, because of when the patient even have the same diagnosis, but it might reflect that they may use more resources, and then it maybe end up with another DRG group.
Yes, thank you, Dr. Bunchai. I think there are no more questions from the participants. So to all our participants, in case you have other questions about the Thai DRGs and the work of Professor Basanta's team with openIMIS, please feel free to reach out to the AN Secretariat team so we can connect you to the right people. Once again, thank you, Professor Basanta and Dr. Bunchai, for sharing your work with the AN community. Thank you, everyone.
Thank you. Bye.
Bye.